Hello and welcome to CEY 2019. My name is Katherine Mastrota and I'm happy to be invited again to CEY. It's a wonderful platform for education. And I am the Director of Optometry for the New York Hotel Trade Council. So I get to see lots of patients who work for the hotel industry and the hospitality industry. And I hope today to discuss with you as seen on TV, or how patients' self-directed care can sabotage your best OSD management plan. So I hope you learn a little bit about the current therapy and things that patients may be doing behind your back that may impact the success of the care that you render to them and the suggestions that you make. Now, of course, on TV is where I got a lot of information, but of course, demographics has changed and our access to social media and informational channels is different. So this is seen on TV or Instagram or found on Amazon or tweeted on Twitter. So think about all these informational outlets that your patients have and where they may be getting treatment plans or trying things that go outside what you're thinking about. 30 million Americans report symptoms of dry eye disease, and only a fraction of those are diagnosed, and even a smaller fraction receive therapy. So we are trying to make an impact across, eye care and getting these patients treated. And I find one of the easiest way, a simple question, is the UNC Dry Eye Management Scale, which is a visual analog scale to help identify patients who may be suffering from dry eye disease. It's very easy for patients to answer this one question that let you know how their eyes are feeling, where one, my symptoms are not a problem and it doesn't affect my daily life at all, to a very severe number 10 that their dry eye symptoms or their symptomatology greatly affects their daily life. This is a quick and easy way to tap into these patients, and also a way to monitor them, because they can just put a mark along this scale and you can just show your patients, where they are and how they've gotten better. So this is a very easy way to identify these patients and get them treated. $3.84 billion are considered the cost of dry eye disease in the United States, and it's loss of time from work, medical costs, drug cost. Dry eye disease is associated with depression, anxiety, sleep disorders, which is another cost of disease. And interestingly, a survey from the Dry Eye Zone group, which is a blog of dry eye sufferers, a little bit on the more severe side, report that they've seen up to 7 doctors. So patients are looking for help, and with your best efforts, they may be doing things that are actually counterproductive to the care that you're rendering. So that's what I hope to bring to light in this presentation. And what prompted this presentation and the thought for this was this study here, self-medication, initial treatments used by patients seen in an emergency room setting for an eye concern. And in this survey of 561 patients who reported to the emergency room for an eye-related problem, over 40% of them used something before they got there, whether it be a homemade product or a commercial product, something they got in the pharmacy, recommended by a friend or a pharmacist. Many of these were homemade, almost 30%. They included solutions and infusions and all sorts of other home remedies or folk remedies, even in the case of acute ocular injury. So think about what your patients have done and what they are doing, when they come to you, when you ask their medical history and their dry eye history. Patients have many, many choices, and here is just 2 snaps from one of the local pharmacies, and this is only part of the eye medication wall. Some of these medications are seen on TV, some of them are not. These choices are confounding. They're allergy and red eye, and one of the ones that I picked up was this product here, which when you flip it over, the main ingredient is, the active ingredient is tetrahydrozoline, which can cause redness relief. However, rebound redness is a concern in patients using these vasoconstrictors. What we do have, if you haven't been introduced to it, on the market now commercially available to your patients is Lumify, which is a very low concentration of brimonidine tartrate, which we know has been around since 1996 and used in Alphagan for IOP control. However, because brimonidine selectively constricts veins, there's no rebound from this formulation. It's once a day, twice a day if necessary, and this has been very helpful to me in my practice and with our patient base, very useful for satisfying the cosmesis concerns of patients who work in smoky environments or are bothered by their red eye. So I suggest that you think about incorporating Lumify into your practice because it's been very helpful in ours. Now, when I think about the dry eye patient or the ocular surface disease patient, I close my eyes and I see this diagram. And what it depicts is the ocular surface, which is the yellow wheel around the center of the slide, and all the things that can impact the ocular surface. And although this is a comprehensive list, it really isn't complete. And you can see all these things that we know about, things that interfere with the homeostasis of the ocular surface, whether it be surgery or drugs or blepharitis or allergy. What I have highlighted here is low blink rate and environment. And one thing that we do want to add to this is digital device use. So these are the things we have to hone into when we're asking our patient history, what they do, when their eyes bother them, and your dry eye history. In the center of this circle, we really have what's thought to be the underlying cause of symptoms and signs of dry eye disease, which really bubble down to inflammation. This wonderful, wonderful image has been updated to have an internal loop related to meibomian gland dysfunction, but this certainly is a very useful thing to think about when you're evaluating your ocular surface disease patient. We highlighted computer use and blink rate, and I live in Brooklyn, New York, and I travel all the time since I don't have a driver's license on the F train, and every morning this is the view that I see. You look to the right of me, everybody's on a digital device. You look to the left of me, everybody's on a digital device. And this is every day, whether I'm on the F train, the A train, the G train, or the C train. So this is a part of the world that we live in now. And toddlers and also infants have devices that are either digital or look like they're digital. On the left we have a toddler with an iPad, but on the right, this cell phone device is actually a toy that was in a stroller for an infant. And I asked the parent if I can take a picture of this. There's a little infant playing with this toy cell phone that just gives you an idea of the urgency and the immediacy and how early we are beginning with digital devices, which we know are related to reduced blink rate and also believed to be a factor in meibomian gland dysfunction because of the change of the blink and the pump mechanism of meibomian glands. In a recent study by our colleague Justin Kwan, you see that patients use not only one screen but multiple screens, where 7.8% of patients use up to over 3 monitors. So the amount of screen time that we have, and in this particular example, in non-ergonomic positions, and up gaze and left gaze and right gaze, these are all questions that we have to ask our patients and be cognizant of what they're doing with their eyes on a daily basis. Of course, to make it easier, you can see this on TV, you can get this little gizmo that hangs on your neck and holds your cell phone for you, whether you be sitting in the park, in your bed, or driving in your car. And this lovely young lady on the left, asleep on her phone, is my daughter. So you can see that this is something that I take close to heart and something that you should too. So these are the gizmos that your patients have to extend the amount of time on their devices. Recently, the Ocular Surface Academy, which is the brainchild of our colleague Scott Schachter, posted this on Instagram, that those biggest engineers and IT people in Silicon Valley now are beginning to take to heart the effect of screen time on their children. And this has been featured in 2 New York Times articles. So once again, this is something that we have to discuss with our parents and their children, and how to have a healthy visual lifestyle. One thing that I was very happy to see, at least on iPhone, is a screen time app which can let you monitor your own screen time and set limits for other users on your subscription. So this is something that is an eye-opener, and no pun intended, that how you can actually monitor your own screen time, and patients can monitor their screen time and perhaps set their own limit. So this is something that I think we're all beginning to recognize. So if you have an iPhone, look into this, and this has been very helpful to me. Nothing makes a woman more beautiful than the belief that she is beautiful. However, we have lots of individuals and patients who want to make themselves more beautiful or approach an image of beauty that is generally preferred. So we have lots of ways to change our features, and products range from very light and easy ones to products that are made for long-term staying power, such as this 24-hour waterproof eyeliner tattoo effect pen. And these cosmetics have waxes and oils that help keep them affixed to the skin and the lid margin, blocking meibomian glands and delivering themselves into the tear film. So this is something that patients have access to. And another thing that I was surprised to see that available to any untrained person is a eyeliner tattooing pen on the left and a practice skin on the right. So untrained individuals have access to this type of treatment to tattoo their own eyelids. When you do that, something like this can happen, and this nice lady came in to see me, and the chemosis and ecchymosis of her lids to her was not as impactful as the discomfort and tearing. She had suffered a keratitis from the repeated application of product to her eyelid margins, in and above her eyes, and the tape. So this is a 24-hour post-procedural patient, and this is something that patients have to be reminded of. The pigment from tattoo pens can be deposited onto the cornea, and here is a case where pigment was deposited to in between the stromal lamellae in this one particular patient. We have another case that the conjunctiva was pigmented at the limbus, and yet another case where the whole eyelid was penetrated with the needle and the bulbar conjunctiva was pigmented with tattoo ink. So these are things that happen and not reported as frequently as they happen in our practices. It's interesting to remember that tattoo inks contain heavy metals, including titanium oxide, lead, chromium, nickel, and iron oxides. And these remnants of these in the eyelids can actually show up on MRI and can be visualized with, on these imaging studies. So not only